Well, a warm welcome to everybody joining us today from wherever you're from. Thank you for registering for today's event and thank you for taking part and being part of this today. My name is Chris Smith. I'm a paediatric dietitian from the Children's Hospital in Brighton in the United Kingdom, and I will be your host for today's webinar. The title of today's webinar is When Whole Protein Feeds Are Not Tolerated. And we have two experts who are going to guide us through and share with you the most current literature around these topics and also share with you their own insights and some new data too. So this promises to be a very exciting and a very interesting webinar. I'd now like to take the opportunity to introduce our two speakers for today. Our first speaker is Professor Nikhil Thapar, who is the Director of Gastroenterology, Hepatology and Liver Transplant at Brisbane Children's Hospital, Australia. Many of you will be aware of Professor Thapar's extensive work, much of it undertaken at Great Ormond Street in London, but also extensively within ESPGHAN and NASPGHAN, and now within the Australian and Asian societies too. His depth of knowledge and practical abilities in research and in patient management is absolutely invaluable. And in particular, his research in the enteric nervous system makes him the perfect choice for the presentation today. So we're very grateful for Professor Thapar for his involvement today. Our second speaker is Dr. Roseanne Meyer, who is a paediatric dietitian and a clinical lecturer at UCL in London, as well as being an associate and visiting professor at Louvain in Belgium. Roseanne is extensively published in several areas of paediatric nutrition, including allergy and GI, and has big involvement in many European bodies. Again, she has a wealth of experience and her input and insight is invaluable for today's session. So thank you, Roseanne, for being part of this today too. So I'd now like to invite Professor Thapar to present his presentation to us, which is entitled The GI Tract as an Intelligent Organ, Food for Thought. Thank you, Nikhil.
Hello, it's great to be able to present to you today, especially because this is a topic which is very close to my heart, or I should say close to my gut. It is also a topic which is increasingly important to our day-to-day practice. Needless to say, there's often more questions than there are answers. So the center of the universe. Oh wow, the gastrointestinal tract. Possibly one of the most important and amazing organs of the human body. But don't just take my word for it. Ask the most important minds of our time. The gut first and foremost. Now, what I would like to do in this talk is to really provide you with the concept that the gastrointestinal tract is an intelligent organ. That it is part of a very critical collaboration called the microbiota gut-brain axis. And that this axis is responsible for orchestrating highly coordinated function and exquisite nutrient sensing that occurs within the gastrointestinal tract, and that these processes are really essential for normal biological responses to feeding. I will discuss the fact that often normal feeding is not possible and one needs to go for enteral feeding, and I want to try and explore how enteral feeding might interfere with these normal biological responses and might help us understand or consider what are the best routes and types of feeds that we may consider in these children. Now, whether or not you believe in the theory of evolution, what is clear is that the first complex organisms that inhabited the earth lacked an organized or robust central nervous system or brain. So they were often worm-like creatures, even the first ancestors of man. And instead of a brain, they had a very large gut tube which ran from the mouth to the anus. And this gut tube appeared to coordinate the functions of the body. So therefore, if it was acting as the brain, then one would assume it had a nervous system capable of the very complex function of the brain. And indeed, we know that this is true because the brain of organisms, especially that of humans, contains a very large and robust inherent nervous system of its own known as the enteric nervous system. And this is so large that it is equivalent to the spinal cord in terms of the number of neurons that it contains within it. And it actually carries the complexity of neurotransmitters that you would expect within the brain itself. And it is this enteric nervous system that is able to coordinate the functions of the gastrointestinal tract. And this is not only digestion, absorption, and excretion, but it is involved in homeostasis of the body. It is involved in coordinating immune function. We know that the vast bulk of the immune tissue present within the body sits within the gut. We're going to discuss a little bit later on the vast endocrine functions of the gastrointestinal tract. It is incredibly important for growth, how we adapt to the environment, and increasingly, we know how important it is for psychology and well-being. And this is only the tip of the iceberg. Now, it is quite clear that the enteric nervous system doesn't function by itself, but it functions in collaboration with a vast community of microorganisms, bacteria, viruses, fungi, protozoa that sit within the lumen of the gastrointestinal tract, namely of the large intestine. And together with the enteric nervous system, these are hardwired to the central nervous system, and this collaboration is known as the microbiota gut-brain axis. And all of these elements of the microbiota gut-brain axis are constantly communicating with each other through neural and humoral routes and adapting the body and establishing health. Now, we know that it's very critical for health and well-being of individuals, but we also know that disruption of the microbiota gut-brain axis is also very important in disease. And if we look at some of the most common disorders that we see within children, so these are functional gastrointestinal disorders, we now refer to these disorders as disorders of gut-brain interaction. And in the same way that the microbiota gut-brain axis is so essential for health and well-being, we also know that it forms the fundamental basis of control of biological responses to feeding. Now, often when we think about feeding, we think about the ingestion of food, but I want to remind you that actually the responses to feeding start well before we actually ingest any food and really continue throughout the period between meals, throughout the so-called fasting period. And these are really critical for the optimal utilization of the meal. Now, if we think about the biological response before feeding, this is known as the cephalic response. And this is really important to try and prepare the body for receiving the food and optimally dealing with it in terms of digestion and absorption. It also appears to control appetite and satiety. Now, of course, this was very well explored by Pavlov and his dogs, and he showed that by exposing to or conditioning the dogs to the sight, the smell of food, or indeed the ringing of a bell around meal times, that he was actually able to induce biological responses in the dogs that prepared them for the meal. And that's exactly what we would expect to see in children. So therefore, if we actually show food, or we see food, or we smell food, or we have an expectation of food, we start to see biological responses, for example, within the mouth, where you get saliva production, within the stomach, where there's an increase in gastric secretions, and even within the small intestine, where we start to see an increase in the production of digestive enzymes and secretions within the gut and changes within motility. And we know that these are really essential to optimally digest and absorb food. Now, in fact, Pavlov, back in his experiments, cheated the dogs at some point because he placed food into the stomach of the dogs using a tube when they didn't expect it. And what he actually found is that the food remained in the stomach for longer than if they were allowed to go through the cephalic response, and the food was not digested as well. So therefore, the cephalic response is extremely important for us to actually feed appropriately. And in fact, not very far away from me here in Brisbane, in Australia, within the neonatal unit around the corner, they are actually exploring the use of things like the smell of milk and the taste of milk during tube feeding of preterm infants to see whether they're actually able to improve the tolerance of feeds by trying to evoke the cephalic response within these preterm infants. But now let's think about the biological responses to the actual ingestion of food. So when you take food into your mouth, of course, you're going to taste the food. You start the process of mastication, where food is broken down into small pieces. You add saliva into the mix. This is both bactericidal and also provides lubrication and starts the process of digestion of carbohydrates, releasing simple sugars, which can be easily absorbed at the beginning of the meal. Food is then propelled through the esophagus into a very clever organ, the stomach. And this acts in many different areas. One is that it is a reservoir for food. So it actually accommodates to allow you to take in the meal, which also determines appetite and satiety. It is a very powerful muscle, which then grinds the food into small pieces. And these, especially the small pieces, are driven and propulsed towards the small intestine. Very importantly, it produces digestive enzymes and acid, which are not only bactericidal, but help in the digestion of protein. And then in a very carefully coordinated fashion, food is passed carefully to the small intestine, where it is mixed. It is propelled down towards the large intestine. And really the bulk of digestion and absorption of macronutrients and micronutrients and trace elements and water as well occurs within the small intestine. And eventually, this is now moved on after the extraction of valuable nutrients to the large intestine. Now, often the large intestine is an underrated part of the bowel. It's not only a storage organ and it's important for excretion, but of course it houses the vast bulk of the microbiome, this important community of microorganisms. So therefore it provides them with essential nutrition. It also maintains health within the bowel, and it is critical for the absorption of salt and water. Now, of course, when I present all of these different segments working in their critical fashion, it appears that they're all working in isolation. But of course, we know that this is not the case, that the gut is constantly talking to itself. So one part of the bowel is talking and receiving feedback from other parts of the bowel, and that really modulates function. Now we see this, for example, within the stomach, where we know that the presence of food within the stomach or nutrition within the proximal small intestine is able to signal to the large intestine to induce mass movements. And of course, this seems to be in readiness of the large intestine eventually, a number of hours later, receiving food which is passed down the small intestine. There's also feedback occurring from the colon. So if the colon is not able to clear itself, for example, if you start to fill your distal colon, signals are sent back up to the stomach. This is known as the cologastric brake, which really reduces stomach emptying and reduces appetite. And this is classically seen in children with constipation. When they cannot clear their impacted stool, they'll often lose their appetite and their hunger, and this is restored once the bowel is cleared. Now, this incredible signaling that occurs within the bowel can be seen if you actually put sensors within the small intestine. Now, what we know is that fasting, so this is the period in between meals, is very important for digestion, absorption, and the movement of food. So what we see in this fasting phase is a very critical contractions occurring within the small intestine, and then every now and again you get this big mass movement known as a migrating motor complex, which moves down the small intestine and propagates food down towards the large intestine. And this is it shown in high resolution. Now, in the middle of this migrating motor complex, if you would allow a child to eat, what we see is that literally within minutes of ingestion of food, for example, in this case, a chicken sandwich with some crisps, we see a change within small intestinal contractility. So we lose this kind of incoordinated contractions and the migrating motor complex that's moving down. And we see that there's a complete change occurring within minutes of food being taken into the mouth, occurring both within the stomach and the small intestine. Now, this is within minutes, so almost too fast for an expectation of food to arrive within the small intestine to change its behavior. So what underlies this? Well, clearly, taste receptors within the mouth are critically important. We know that we have taste receptors, and also that these taste receptors are even pretty well matured in newborn life. So here we can see from this publication by Catherine Forrestel, the response to a baby, I think at about 2 hours of age, to the presence of sugar or sucrose given into the mouth, and also of a bitter substance like quinine, to actually show that these are quite mature responses. So therefore, it's likely that we are able to control the lower gut by the arrival of food in the mouth. But what is most interesting is that not only do we have these specialized taste receptors present within the mouth, but in fact, they are scattered throughout the gastrointestinal tract. So these are enteroendocrine cells, and really put together form one of the largest concentrations of endocrine tissue within the human body. So these are specialized cells, and we can see that they have microvilli at one end where they are able to sample the lumen of the intestine. So they're able to sample for the presence of glucose, of fatty acids, amino acids and peptides, as well as fats within the lumen. And they then are stimulated to produce a variety of gut hormones, which are secreted into the bloodstream. And these will really control very critical things such as the secretion of digestive enzymes and other juices within the gastrointestinal tract. They will regulate things like gastrointestinal motility, satiety, appetite, insulin release, and how you actually utilize nutrients within the gut. Now, the importance is that they aren't randomly scattered within the gut, but are very carefully organized along the length of the gastrointestinal tract. So, for example, if we look into the proximal stomach, we see that they are specialized nutrient receptors or enteroendocrine cells that are able to sense the presence of sugars, for example. Now, we know that accommodation is largely a neural reflex, but we know that the sensing of sugars can actually produce ghrelin, which is a hormone which is very critical in the control of your hunger response. Of course, the job of the stomach is to digest protein and break it down into peptides and amino acids. Therefore, it's not surprising to see that in the distal stomach, we have nutrient receptors which are able to sense the presence of peptides and amino acids and either upregulate the production of acid and pepsinogen, for example, through the secretion of gastrin, or actually downregulate gastrin release through the production of the hormone somatostatin. If we move further down the small intestine, we see receptors which are not only able to sense the presence of peptides and amino acids, but of long-chain fatty acids, and produce a very critical hormone important for digestion known as cholecystokinin. And this is important to increase the production of digestive enzymes, and also is important to control satiety and gastrointestinal motility. And then further down the small intestine, we can see that there's now sensing of sugars, and this helps regulate glucose levels through coordination of insulin levels, and also effects on satiety and motility, and so forth. A very, very clever system. So therefore, when we actually look at the biological response of feeding, we see that it starts well before the receipt of food into the body. It then continues with the ingestion of food with a very coordinated response throughout the length of the gastrointestinal tract, with constant nutrient sensing, which is constantly adjusting motility, constantly adjusting secretions and movement of the food through the gastrointestinal tract. And even after this is completed during the fasting period, we see that digestion and absorption continues, and you start to get mass movements which gradually move the feed down towards excretion from the body. Now, we know that in a number of children, it is not possible to feed normally and use all of these responses. So some children we know cannot feed by mouth, and we have to provide nutrition in an adequate form through tube feeding, which is either into the stomach or further down into the gut. And this, of course, is known as enteral feeding. Now, enteral feeding has been around for a long time. So we know, for example, that the ancient Egyptians and the Greeks used to actually place food into the rectum. Not a very successful method, clearly. And really, over the centuries, enteral feeding has really evolved. It's seen its real progression in the last, I would say, 40 to 80 years, first with the advent of specialized formulas, which occurred in the first half of the 20th century. And then over the last 40 years, we've really seen enteral feeding become something that we actually use routinely in clinical practice. And of course, there's clear indications for the use of enteral feeding. So like I said, if you are unable to feed orally or unable to feed sufficiently orally for growth and development, then you would require enteral feeding. Now, we see this in children, as I will mention in a second, who are unable to swallow effectively or have an unsafe swallow if there are congenital abnormalities of the upper gastrointestinal tract. Increasingly, we see children with severe feeding aversion or behavioral disorders, and also in children who are critically unwell, they may also affect their oral intake. Enteral feeding is very useful where you have disorders of digestion and absorption, either because the food cannot be absorbed effectively enough, or you don't actually have sufficient gut length, such as in short bowel syndrome, to really effectively absorb enough nutrition to allow for growth and development. In certain situations, the actual metabolic or nutrient requirement is so high that it is insufficient to feed children through their normal oral route to provide nutrition. So therefore, if we're looking at conditions such as cystic fibrosis, looking at burns injuries where there's a very high nutrient and metabolic turnover, in chronic diseases, you might need to rely on enteral feeding. And finally, in some conditions, you actually use enteral nutrition as a key component of disease management. And we know that in cases of inflammatory bowel disease, namely Crohn's disease, and in conditions such as epilepsy and inborn errors of metabolism. Now, if we look at some of these cases, we've done a lot of work recently in children with neurological impairment, and in a couple of years ago wrote some guidance for assessing and managing nutrition within this group of children. Now, we recognize that in children with neurological impairment, a significant proportion of them, and possibly all of them, have a degree of oropharyngeal dysphagia, especially those with severe effects on gross motor skills. And we know that actually enteral nutrition within this group of children is very effective. So therefore, we actually recommended that in these children, after careful assessment of nutrition, enteral nutrition may be a very valuable route to start early on before the development of undernutrition, and that it can have significant beneficial effects, not only on nutritional status, but on health-related quality of life. And relatively speaking, it has low rates of serious complications. In many of these children, you can either use gastrostomies or post-pyloric feeding, but still there remains a lot of debate on the actual choice of enteral formula that needs to be used within this group. And apart from children with neurological impairment and children with obvious gastrointestinal disease, the other big group for the use of enteral feeding are really children with cancer. Now, of course, there's many reasons to why these children may require enteral feeding. They often run through periods when they are extremely unwell. We know that both through the condition itself and for the management of the condition, they suffer significant side effects, such as a loss of appetite and nausea and vomiting. They can develop mucosal inflammation, which also limits oral intake. And therefore, enteral nutrition can be very effective within this group. And we also know that they experience much more in the way of actual behavioral feeding problems. Now, within this group, there are particular diets which are being trialed for actual treatment of cancer itself, such as calorie restriction, either intermittently or persistently over the treatment of the cancer, and ketogenic diets. But in terms of general enteral feeding, as we shall discuss later on, there's really a lot of debate around either the route that needs to be used in these children or actually the type of feed which is optimal to use. But whatever condition you were really thinking about in terms of the use of enteral feeding, there's some considerations which are really universal. So this is an algorithm, for example, we developed in children with neurological impairment, which really says that if you have adequate oral nutrition, but you cannot make it safe, or if you have inadequate oral nutrition that is safe, but you cannot optimize or is unsafe, then that really provides an indication for you to consider enteral feeding. But of course, the type of enteral feeding may depend, for example, on how long you may need this nutritional support. So therefore, prolonged nutritional support, you might swap over from having either a nasogastric or a nasojejunal tube to actually place tubes directly into those parts of the anatomy. And of course, depending on whether there's a risk of aspiration or poor gastric tolerance, you may decide whether you feed into the stomach or you feed post-pylorically into the jejunum. The most common mode of feeding is going to be of gastrostomy feeding or feeding into the stomach using a nasogastric tube. Now, what I want us to remember during this seminar and listening to Roseanne's talk and the discussion thereafter is really what the effect or the likely effect of feeding into the stomach and bypassing normal responses is likely to be. So I put up this slide just to remind you of the normal biological responses to feeding. And we can start to guess what would happen if you bypass those and fed directly into the stomach, for example. You would lose the cephalic phase, so that kind of preparation of the gut would be lost. And therefore, you're not really optimizing the responses within the mouth, the responses within gastric secretions as well, because you fast forwarded into the stomach. Now, the stomach is a reservoir, but in fact, most of the feeding regimes we use for the stomach, either through a nasogastric or through a gastrostomy, are going to deliver feed into the distal part of the stomach. So therefore, you really lose the optimal reservoir activity of the stomach. And in effect, you would also start to interfere with normal biological responses that occur within the rest of the gastrointestinal tract. And what's also important to see, as we kind of discuss the data going forward, is that often children who have gastrostomy feeding may also be on additional drugs, such as proton pump inhibitors, and that might actually interfere with the amount of acid that is present within the stomach, and also may lend itself to interfere with normal biological response to feeding. Now, in some children, there is a high risk of aspiration, or there is a poor tolerance of gastric feeding. And in those children, you might consider post-pyloric tube feeding through the nose, or actually the placement of a gastrojejunostomy or a surgical jejunostomy. Now, in fact, when we reviewed this very recently, we were quite alarmed with the rise in the use of jejunal tube feeding. So although I've just explained to you, we would often use it where there was gastric intolerance or a high risk of reflux and aspiration. But in fact, what we were starting to see was a rapid rise in the use of post-pyloric feeding in children. And therefore, a group of experts came together to try and provide some guidance. Now, again, what I want to remind you is that if we consider jejunal feeding, then in the similar way that we considered gastric feeding, and we look at the biological responses to feeding, we see that if we go for post-caloric feeding, we're pretty much eliminating most of the normal biological responses that you would prepare the gut and optimally digest and absorb food. So not only have you lost the cephalic response to feeding and preparing the gut, but you lose the stimulation of the mouth, the esophagus, and the stomach as well. And in almost all of these children, or in fact all of these children, you won't be able to persist with bolus feeding, and you also lose the postprandial or the fasting response that is also so important for digestion and absorption. Often these children will be on complex drugs, which includes acid suppression, and therefore you start to interfere with small bowel function as well. So something really important to keep in mind. Now, we tried to address this by giving guidance as to what feeds one may consider within jejunal tube feeding with the absence of any clear evidence. So therefore, for example, we recommended mostly by expert opinion that you would start, or you should start to feed with a standard polymeric formula. And if this is not tolerated, that you could try switching to a hydrolyzed formula. We expressed caution with the use of elemental formulas and other hyperosmolar feeds due to the high osmolality of these feeds, and also to the use of thickened and fiber-containing feeds due to the risk of tube blockage. We suggested that where you had pancreatic insufficiency or malabsorption, that you might try a hydrolyzed formula containing a medium chain triglyceride. But what is critically important is that you need to monitor nutrition in these children, especially of trace elements and micronutrients. And of course, we also provided advice over the safety of actually providing these tube feeds. So lots and lots of consideration and lots of food for thought when we actually think of enteral feeding within this complex population. So just to summarize what I've hopefully told you that the gut, in fact, is a critically important organ and in many respects was the first brain of the body. It very importantly sits within an important collaboration of the microbiota brain-gut axis. I've talked a little bit about cephalic responses to feeding, not a lot about the microbiota, but it is without doubt that this is a really critical part of our understanding and something hopefully we will get to learn much more in the future. What I've also presented to you is that feeding is a very complex and coordinated process. This starts well before the ingestion of food, with preparation of the gut to receive food and to optimally digest and absorb it. It continues through the ingestion of food with constant communication through all parts of the gastrointestinal tract, which regulates secretions, motility, digestion, and absorption, and then continues through to the fasting phase. And that when we think about enteral nutrition, you really need to keep this global view of biological responses of feeding in your mind to try and make really sensible decisions about the route and the type of feed that you might consider. With that, I'm going to finish and just leaves me to invite you either in person or virtually to come and explore this very exciting area further if you can make it to Australia. Thank you very much.
Well, thank you very much, Professor Thapa, for that fantastic presentation. I think you've taken a very complex mechanism and explained it very, very clearly for us. And I think your point about considering these complex mechanisms when we're actually faced directly with that child in front of us, considering enteral feeds is really very poignant and really very useful. So thank you. And now's a good time to introduce Roseanne for our second presentation. She's going to be talking about the use of extensively hydrolyzed formulas and amino acid-based formulas and feeds in children outside allergy. So thank you very much, Roseanne. Over to you.
Hello to everybody that's joining this webinar. I want to start off by saying thank you very much for being invited to present today. You will have had an amazing presentation already from Dr. Nikhil Thapa and would have had some very practical background, not only on the functionality of the gastrointestinal tract, but also on reasons why intolerances in regards to feeds may occur. Most importantly, also the considerations when you interpret feed intolerances. What I'm going to talk to you today is the HOPA study. It's a survey that we did in the UK, and it's really around the use of extensively hydrolyzed and amino acid formulas in conditions outside of allergy. It's trying to give you a very real life experience in regards to use of these feeds outside of allergy. I want to start off just with my disclosures, which as an overview include academic lectures like these, and I'm also on a couple of the allergy boards as well. Now, in many conditions you see feed intolerance, but the reality is, what is feed intolerance? We have people in the audience today who will have specialized in congenital cardiac disorder versus, for example, short bowel disease. So is it the same thing if somebody's saying a child is not tolerating a feed in congenital cardiac disorder versus short bowel syndrome? Are you actually looking at the same thing? There are many studies that have been performed and varying definitions or interpretations of what in fact is intolerance to feed. What is universal is that the gastrointestinal tract is always involved. That's why you've had this amazing background presentation to give you the functionality of the gastrointestinal tract. However, it's very poorly studied in pediatrics outside of critically ill children. Although each one of us would think in our mind that we know what it means to say a child is not tolerating the feed, the cutoffs or what we define as not tolerating outside of critical illness is in fact very poorly studied. There are many studies that actually use just parent questionnaires, and we know that parent questionnaires are quite subjective. So that's also not a very objective marker to say a child is tolerating a feed or not tolerating a feed. More importantly, outside of food allergy, where there's a very strict criteria for the efficacy and the safety of these feeds, there's in fact not a set criteria for efficacy and safety for using these feeds for the vast majority of diagnoses that it's been used for. And I think part of the reason is that the population that it's being used for is so diverse. So your efficacy and safety data may change between the different diagnoses that you're actually using. So although we think these feeds have been tested in a population that we're using it for, if you start looking at the data specifically, you often find that we use the feeds because we actually feel comfortable. We think it might be working because it's worked in other conditions, but the specific data on the safety and efficacy does not exist. I wanted to use the critically ill patients as an example just because to show the data that has been published, because I think that data isn't particularly good. And there was recently systematic review by Evelyn's and of course Koen Houston, who's a good friend of ours, to look at the symptoms that define feed intolerance in critically ill children. I'm presenting here a combination of category 1 and 2, and that means those where enteral nutrition was stopped not only because of gastric residual volumes, but because of gastrointestinal symptoms. And you'll see outside of gastric residual volumes, which are quite unique marker for intolerance in critically ill children and also highly debated, the other symptoms, including diarrhea, vomiting, abdominal distension, constipation, all of those are symptoms we would also see that might be an indication for why a feed may not be tolerated. You will now also know that there are lots of reasons outside of feeds why a child might have diarrhea, why a child might have vomiting, and that's important to take into account. So when we started setting up this study, We in our mind did not think there was confusion about the terminology, but when we wrote up this article, we realized that there was a lot of confusion in regards to extensively hydrolyzed formula versus semi-elemental, amino acid versus elemental, because I think there is the thinking that extensively hydrolyzed is always for cow's milk allergy and semi-elemental is always for feeds outside of cow's milk allergy. However, if we look at the definition, an extensively hydrolyzed feed, the majority of peptides are below 1.5 kilodaltons. So an extensively hydrolyzed formula can be suitable for the management of cow's milk allergy, but it has to be tested in Turin with a proven cow's milk allergy, and there are set criteria for that. So that does not mean all of the extensively hydrolyzed formulas are immediately also suitable for cow's milk allergy. Extensively hydrolyzed formulas also have sugars as glucose polymers, and they have varying levels of MCTs. Semi-elemental feeds can be extensively hydrolyzed, but they can also be partially hydrolyzed. So they actually encompass both, but they also contain glucose polymers and starches. So for us, for this study, we actually said that extensively hydrolyzed is the same as semi-elemental, because semi-elemental feeds can be extensively hydrolyzed, and also the glucose polymers and MCTs. So that's how we interpreted it. And for amino acid feeds, actually it's much easier because all amino acid feeds contain just amino acids. They also contain glucose polymers and variety of fats, but not all amino acid feeds have been tested for allergy. So for us, for this study, we said extensively hydrolyzed is semi-elemental, amino acid feed is elemental. And I think for future, this whole confusion needs to be addressed with better definitions around elemental and semi-elemental. In my mind, it seems much easier to say extensively hydrolyzed or amino acid, but that's just me. Now, in this survey, we had several objectives. We wanted to look at the descriptive population that use the extensively hydrolyzed formulas. We wanted to also look at the indications for extensively hydrolyzed formula and amino acid formulas. We wanted to also look at the type of feeds includes and the concentrations, whether they would changed at all, diluted or made more concentrated, their feeding route, growth status, whether there were any deficiencies measured by biomarkers, and also vitamin or mineral supplementations. I want to just say it was a survey. So our ethics application actually just says we do not do additional bloods. So we actually just took at a time point what data is routinely available for that patient. There were 20 tertiary centres in the UK at that time that we had complex pediatric patients. We approached 8. Now, of course, you immediately can see that biased the type of population that we recruited, but we approached those because this is a lot of work, and we knew they had dietitians that would be able to recruit patients for us. 4 out of those centres agreed to participate, and I've shown you here they're mainly in the south of the United Kingdom. These 4 centres had a variety of patients, from congenital heart disease, critically ill patients, and those that required intensive care, also preterm infants with gastrointestinal disorders, neurodisabilities, congenital or acquired intestinal failure, cholestatic liver disease, and various cancers. And data was collected between February and October 2018. We asked centres to collect at least 25 patients. Now, the inclusion criteria was actually very broad. We said any child between 0 and 18 years of age consuming an extensively or an extensively hydrolyzed formula or an amino acid formula as part of their enteral or nutrition. It can be oral or via tube feeds. And we asked that at least 25% is provided with this either of these feeds. For exclusion criteria, we excluded those children with a confirmed IgE or non-IgE mediated cow's milk allergy, and we also those children with suspected non-IgE mediated cow's milk allergy or multiple food allergy, and with eosinophilic gastrointestinal disorder. So we really did not want any patient that is allergic, focusing on the population outside of allergy. Now, we managed to get 191 patients, just above 50% were male, 21% were born preterm, and the median age at the time of data collection was 19 weeks. The median gestational age of those that were preterm infants were 30 weeks of gestational age. Now, I'm not going to go through individual data points because it's a very data heavy survey, but I want to just give you a few. The vast majority of our patients actually came from an intensive care unit, and you'll see for them, the vast majority were on these feeds, and it was standard practice in that unit that recruited the patients to use an extensively hydrolyzed whey formula. It was energy dense formula. Then we had patients who had cancers, who are our second biggest population that we recruited, gastrointestinal diseases, that doesn't come as a surprise, liver disease, and then we had other, which were neurodisabilities, chromosomal abnormalities. Some were preterm, and the smallest category were outside of intensive care, we're on the general wards with cardiac disorders. As you can imagine, the split was what you would normally see. Vast majority were on an extensively hydrolyzed and a smaller number on an amino acid formula. Now, I think this is a really good slide to focus on. We wanted to look at the route of feeding. And what really surprised us is that the vast majority, if you can just see, only 10% of the patients actually were orally fed. The vast majority, more than 70%, had a nasogastric tube. And a small number had nasojejunal tubes, some had PEGs, some had PEGs as well. So that already indicates the complexity of the patients that are on these feeds. On top of that, these patients were on polypharmacy. So this is the medication used. And so we've split it up in the type of medication. And you can see, again, a huge number of patients. So 77 out of our population of 191 were on proton pump inhibitors. Then, of course, as we had quite a number of patients from that had cancer, we had lots of them on antiemetics, and then the number of medication reducers. So already we can see these are children that are nasogastrically fed, that are on polypharmacy. And you've seen already with the previous presentation how the route of feeding, where you're feeding to, just bypassing the mouth and going directly in the stomach, actually affects the motility and the digestive process. Add onto that, proton pump inhibitors, you again change the way, not only in terms of the motility, but actually also the bioavailability, how the micronutrients are absorbed. We also looked at the energy contribution. Now look at the pink part here in the pie chart. So that is, if you think 75 to 100% is the contribution of the feeds. So you can see for the vast majority, it doesn't matter if you look at the total population or the extensively hydrolyzed or the amino acid, actually the vast majority received this as a main source of nutrition, between 75% and 100% of their feeds. We also here have a heat chart to give you an indication of the length of time they were on these feeds. Whilst the vast majority were on it just within the PICU environment within 1 or 4 weeks, you can actually see here that we had a big number between 3 to 12 months. In particular, those patients with cancer, those patients with GI diseases, between 53% and 35%, between 3 and 12 months. So we have nasogastric tube fed, polypharmacy, and many of the patients actually having these tube feeds with these specialist formulas for long term. Now, reasons for using the extensively hydrolyzed formulas, amino acid formulas, we've also tried to categorize. Now, again, this is a heat map. So the darker the color that you look in front of you, the higher the percentage and the higher the use. So for the vast majority, it was in PICU, and that was standard practice. And as I said, that center had really researched and published the use of the energy-dense, extensively hydrolyzed formula and the tolerance. But then we have here just a group between cancer and GI disease, where in particular they just said not tolerating standard whole protein feeds, where in the cancer patients it was vomiting, in the GI disease it was really your congenital congenital acquired pathology, where the majority of it was an indication. For our liver disease, it fell into the other category with malabsorption. Totally understand that is, we have had many of them with cholestatic liver disease, that you can understand. Prematurity, here again, is the congenital acquired pathology. But we had also in cardiac disorder a lot of them that had that just did not tolerate the standard feed and were vomiting. I want you to just have a little bit of a look in the other category. So we did have, outside of liver disease, other, where there was no specific reason why they decided to use it. It was just marked at other. Of course, this is where there's a limitation of this study, is that other is not always, if we had an interview with the center, we would be able to find out better why they made the changes. Now, we did multiple logistic regression analysis, and I know many of our listeners know exactly what to do, but I just wanted to clarify. We used all of the variables, and you kick out of the model those variables that actually make no statistical difference. So the variables that you see in front of you are those variables that actually made a statistical difference. Now, what you need to see here is the pattern. If you had diarrhea as a single variable, your probability of using an extensively hydrolyzed formula would be high. And similar, if you had malabsorption as a single variable, your probability would also be high, and you would not be using an amino acid formula. And that's quite normal. However, the more complex the combination of symptoms, for example, malabsorption, vomiting, and diarrhea together, and in particular if you were a boy, the probability of actually moving over to an amino acid formula is much higher. And that's what we see also in clinical practice. The more your symptoms, the more is the likelihood of you moving over to an amino acid formula. We also looked at growth. So for growth, what I wanted to see is the overall leanness, so weight for age Z-score was minus 1.2. So that is well below what we would be seeing in the UK as a general population in terms of weight for age. More importantly, these children were short, so at minus 1.3 for a whole population. We did not see any statistical difference in terms of the growth parameters between the different feeds, either EHF or AAF. Now, I'm not going to go through these specific points, but I want to show you the overall feeling. So if you look at the weight for age Z-score, in particular, the cardiac patients are those that were extremely lean, and the cholestatic liver disease, it's for our GI disorders only about a third. More importantly, stunting, so that's defined as minus 2 Z-scores. We found that in the cardiac population, stunting was prevalent in the PICU patient 55% and 88% of those patients that were out of the PICU. So stunting, as per WHO, was extremely prevalent and similar to the patients with cholestatic liver disease. GI disorders, it's around 30% for both stunting as well as wasting. For vitamin and mineral supplementation, 44% of the overall population had a multivitamin prescribed. It doesn't come as a surprise that vitamin D was the most common surprise single nutrient, and we saw for both vitamin D and iron that this was more prevalent to be prescribed in your amino acid formula. And that links in to when we looked at patients' data where blood was taken, we saw higher recorded levels of deficiencies in our amino acid formulas versus our extensively hydrolyzed formula. But again, this is just reflective of the complexity of the population. As you saw with the logistic regression model, is the more complex the patient is, the more you lean over to an amino acid feed. And we think that's the same also for the vitamin and mineral deficiencies. They were also more likely to have vitamin and mineral tested from blood levels, which was actually only about 29%. which made us wonder, because actually many of them had tube feeds for a longer period of time, and one should actually be testing vitamins and minerals on an interval phase to think is this patient actually receiving all the micronutrients. So if we move on to the limitations, I've already pointed out one big limitation, which is of course that it was biased because we selected our units. So by no means what we are presenting today is reflective of how these feeds are used all over the UK, but it gives us a good flavor. The survey of the reasons for using feeds, we had to put it in categories. It was impossible, but that limited the people that took part in this survey to specific categories. So the finer, for example, the other categories, we could not really capture. We used the opinion of the clinician. We did not ask for do stool samples, do measurements to see if there's malabsorption. So we did not have very objective markers, and we had no data from parents. And remember, this was a survey where we took a snapshot. So these patients were not followed up. We just had a single measure at that time. But there are lots of practical considerations already for coming out from this survey. That the extensively hydrolyzed feeds are used for a variety of different diagnoses. It is often led by local practice, now where it may or may not have been assessed. So the one unit, as I already said, in intensive care, they've assessed it and they've published on the energy dense extensively hydrolyzed whey formula. But in many of the units, it was just, this is the done thing, this is what we do, and our impression is it's working better. These feeds are used in patients where whole protein feeds are not tolerated. But the GI symptoms differ and criteria differs, and that changes from center to center. We also found that commonly feeds are changed without a very specific reason. And I think that is a very important consideration to take for the future, is why are you changing it? Especially if these are feeds that have not had any efficacy and safety data. Why are you changing it? What are the risks? Children on these feeds are extremely complex. They've got complex diagnosis. They're fed via nasogastric feed, so they're enterally fed. They're often malnourished, and stunting is very prevalent. There are multiple medication, and often nutritional bloods to assess adequacy are not done. I'm going to move here back to the practical considerations and using the critical illness as a model, because there is no criteria that's very specific for the patients that we're using these feeds for. You might have for short gut, for example, in terms of tolerance, you might have, if there's stoma output, that's much more tangible. But for critical illness, they've actually come up with a criteria based on two criteria: insufficient enteral intake and the presence of at least one of the following criteria, which is gastric residual volumes, presence of vomiting, and presence of diarrhea. Now, of course, gastric residual volume is very specific, but they have good definitions of what is the presence of vomiting, what is the presence of diarrhea. And so I think that is something we really need to work towards better defining for feed intolerance for other populations. In the absence of guidelines, I think we've also come up with some very practical considerations. The first factor is consider the route of feeding and whether the digestive process or nutrient absorption and digestion has been affected. You've had the background now from what Dr. Nicole Thapa has presented today. When switching your feeds to an extensively hydrolyzed formula or to an amino acid formula, I think it's really important to consider a graded approach. Some children just do not tolerate if you just switch one feed to another feed. And this approach needs to be adjusted based on the feeding regime, whether it's at hospital, whether it's at home, whether it's NG, whether it's oral, you might have a different regime, and also whether it's continuous or bolus feeds, you might change your regime. From the outset, you need to have really objective markers of tolerance, and these need to be agreed with the parents. Because I have often found that parents come back and say, not tolerated. When you say to them, what specifically, they would say to you, I'm not sure, but I feel that something is not right. And so it's important that from the start you say, okay, this is what we agree is not tolerating a feed or tolerating a feed. Ensure that growth measurements are done before you start this, and also that you do it during the process. This is an objective marker, because remember, your nutrient requirements, that includes energy and protein, may differ between the populations, and you are embarking in many of the cases on using a feed that may not have been tested for efficacy and nutritional adequacy in that specific population. Monitor your micronutrient intake and assess the child clinic for any signs of deficiency, and consider assessment of your targeted vitamins and minerals. And I would really urge you to look at the Aspican guidelines from 2020, because of course they highlight which vitamins and minerals are accurate when you are looking at it, and also which are affected by your acute inflammatory response, in particular in critical illness. In terms of general recommendations, when an extensively hydrolyzed amino acid formula is considered for a child that does not tolerate whole protein feeds, think about why you're using it. Don't just use it. What does a feed give you a benefit? Is it because of the protein that are peptides? It's because of the type of fats? Why are you using it? Consider the nutritional content of the feed and whether it's adequate. And I'm thinking here, for example, in terms of preterm infants, these feeds have not been developed for the majority for preterm infants. So if you're using it, you need to consider, is the vitamin D, the phosphate, the calcium ratio the right for that patient? For our gastro patients with short gut, think about where are you feeding? And it might also be that if you're feeding, if you lost certain segments of your gut, that the micronutrient absorption of certain nutrients is not optimal. So children who do not tolerate standard feeds often have complex conditions that affect multiple organs, and they are on several medications, and this also can impact on nutritional adequacy. So monitoring is really important, including growth, which we talked about. Audit your practice, because it's not good enough at this day and age to say we're just using this feed because we think it makes a difference. Outside of these feeds having a cost implication, it might actually that these feeds make absolutely no difference. So audit what you're doing, saying, okay, we're using it this population, this is what we're monitoring, and yes, in our opinion, we're seeing a difference. And also initiate research. This is an area outside of allergy where we often don't have research. I want to end up today's webinar presentation by saying I want to acknowledge the people that were involved in this survey. Without them, this would not be possible. And that's Dr. Louise Marino from Southampton, Chris Smith, who's also here today. He's from the Brighton, and Laura Seeley, she's from Bristol, and Sarah Mansell from King's College in London. So really appreciate these dietitians collecting the data. I also want to say this publication is in print. It's very data heavy, so I know I've rushed through all of the data today, but I hope that at least it gives you a flair of why these feeds are used outside of allergy. And I want to thank you all for your attention and for the opportunity to present. Thank you very much.
Well, thank you, Roseanne, for that fantastic presentation. I think you've done an amazing job at collecting a vast amount of data and helping to focus it down on some key clinical points there. And I think your slide on the practical considerations is very useful in clinical practice.
Thank you very much. And thank you also for having us here for this webinar.
Yeah, that's great. So now I'd like to invite you both back, actually, Roseanne and Nikhil, to answer some Q&As with us. Now, we've received a lot of questions throughout this webinar, which I think is reflective of the ideas and thoughts that are generated with really high quality presentations such as yours. So we're going to try and get through as many of these as we can. Roseanne, let me start with you. For the term peptide-based feeds, can you please clarify where this fits in the context of the terminology of the hydrolyzed formulas?
This is a very good question, Chris. And as you saw with my presentation, I highlighted this confusion between semi-elemental and hydrolyzed, extensively hydrolyzed. A peptide feed actually just means that the protein has been hydrolyzed to peptides, but it doesn't specify the length of the peptides. So if you just talk about a peptide feed, it actually can be partially hydrolyzed and it can be extensively hydrolyzed. So I think a peptide feed, you need to go into the detail and say and see. But as I said in my presentation, I think there is a need for us to clarify the terminology better that we are just throwing around and using, because there's a real clinical implication.
Great, thank you, that's great. Nikhil, your first question here. So what are the definitions of the terms malabsorption and maldigestion? And how would you differentiate these two terms in clinical practice?
Okay, well, thank you very much, Chris. Well, maldigestion to me would just mean that you are not basically breaking macronutrients down to their basic constituents, and then that in itself might stop you from absorbing them. Malabsorption might actually mean you can break these down, but you are not actually able to absorb them. And you might see that, for example, if you had the lining of the bowel that's affected, like in celiac disease, where you actually lose absorptive surface. So one is that you're just not breaking them down effectively or digesting them effectively. The other one is that you're not actually just able to absorb them. Now, in terms of how do you tell them apart, it can be extremely difficult. And I think that's one of the big challenges we have. And often the symptom profile that we will see in both is going to be similar, because you might see an increase of symptoms the more you give, for example, of that particular food that you're maldigesting or malabsorbing. And often it might be down to looking at kind of markers or tests to try and indicate, for example, whether you are producing enough pancreatic enzyme. So you might do a stool elastase, for example, which might tell you that it's the issue might be around digestion rather than absorption itself.
Perfect.
But not easy, not straightforward.
Great. Actually, in staying with you, another question for you is, could you comment on the use of amino acids versus peptides in the treatment of induced mucositis? You did mention about oncology patients in your talk.
Sure. I'm not aware of any specific data which talks about the use of a particular feed for the treatment of mucositis. I know that certain amino acids have been used or have been explored to actually improve the mucositis. So I think methionine, for example, has been studied in that respect. I think the answer is good nutrition as opposed to a specific type of feed for the mucositis, which can be quite distressing for individuals. But I don't think there's a specific feed, as far as we're concerned, that you would target mucositis with to treat it. I think it's really about optimizing nutrition. Roseanne?
Yeah, so I mean, as Chris said, you were so heavily involved in this study. So we looked at it and we looked at the data, if there was any data. And actually, it was what we found was just if you've got mucositis and there is indication of intolerance, then there was consensus rather than any specific data. And we found that it was more experience that kind of moved it. It does make conceptually sense from what Nikhil also presented, that there may be a way that the gut is compromised, but we did not find any specific data to indicate, and I would urge again people to say, if you're using these feeds, then study it. If you're finding it's possible, we need to start studying this.
Yeah, thank you, great. So staying with feed choice there then, so Roseanne, this one's come through for you. Are there any specific indications for switching or thinking of moving to EHF outside of allergy? I think
gosh, that's a tricky one, because as you see, I presented all of these different indications, and I think your indications are going to change depending on the diagnosis you are working on. For me, indications would be, and going down to what Nikhil said in terms of intolerance / malabsorption, is to find ideally a hard marker, something that is objective. and then combining that with your monitoring, whether that's abdominal distension or more vomiting or more diarrhea, because I've often found that we would do stool elastase, but it was normal, but you still have more stool frequency. So I would say to you that if you take a child and use the normative and saying, this is the stool frequency consistency, this is the vomiting, this is the discomfort, and then if it is changed from what you find as normative, then I would try. However, in the absence of the data, monitor, 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 and go back and re-question.
Absolutely. Great answer. Thanks, Roseanne. Nikhil, this one came through for you at the end of your presentation. With regards to the microbiota gut-brain axis, could you comment, please, on the influence of the sterility of enteral feeds on gut tolerance? It's an excellent question.
Okay, I mean, I think what's really important is that you're, a little bit like I said before, your body's an incredible organ, and I think it's really designed to keep you safe. And there's so much possibility for the use of enteral feeds and so much benefit in selected cases, but you then have to be aware that you might actually be bypassing some of the body's own defense mechanisms. And I think both the mouth and the really quite strong acid that we have within the stomach actually presents a very good barrier to infection. And I think bypassing that and delivering feed into the small intestine is really a risk. And I think that's why we suggested that, as you know, try and avoid tampering with the feed if you're going to actually put it down into the small bowel. And we already know how important acid is through the increased risk of infections through acid suppression itself. You know, we do see an increased risk of infections there. So I think it is important. I think sterility of the feed that's being delivered into the distal to the stomach is really critical.
Perfect. Actually, continuing along that same thread, we've got a nice question that follows that is for you, Nikhil, and also Roseanne, for your comment too after. What's your view on using prebiotics in small bowel syndrome in both infants and young children?
Well, I think, I mean, it's open for debate. I mean, I think Roseanne can certainly probably give more experience in that respect. I think the evidence is not there for routine use. I think this is a complex group of children anyway. So, I mean, we don't routinely use it. I don't think, I'm not aware of centers that would routinely use it. So I think there's still a lot of work to be done in that area with regards to what you need to do.
I can concur. I think, Chris, the evidence is more stronger around the probiotic side at the moment. In regards to prebiotic, I think one message that needs to come across is, of course, breastfeeding. If you've got in short gut and the infants, if you've got that available, that's what you should use. Breast milk is very rich in HMOs, so human milk oligosaccharides. And from the data that we have at the moment published is really in the fucosylates kind of category, which is a human milk oligosaccharide, but it's very preliminary data. And I think just rethinking about the concerns about bacterial overgrowth that can occur in short bowel syndrome, I would certainly, as a clinician, need more research to convince me to include this as routine practice.
Fantastic.
And I think, Chris, the other thing is that the small bowel doesn't, bacterial overgrowth in the small bowel is not a normal situation. And I think whether you have abnormal bacterial overgrowth or you're trying to put good bacteria into the small intestine, both of those are going to be an abnormal environment for the small bowel to function in. So I don't think, either putting lots of good bacteria or lots of bad bacteria into the small bowel is necessarily a good thing.
Yeah, thank you for a great point. We've had a couple of questions come in regarding osmolarity, actually. So I guess this is a quick one, perhaps, Nikhil. Is you suggested caution with hyperosmolar feeds in jejunal feeding. What do you define as hyperosmolar? Is there a particular...
Okay, well, I mean, obviously, the osmolality of serum is going to be sitting around in children about 290 to 300 as the top end. So anything above that is going to be starting to move towards a hyperosmolar feed. In the actual paper, when we talked about jejunal feeding, I think there is some evidence that if you start driving the osmolality above 400 in very little children, so say under the age of 4, or if you start even going above that in older children, then you are probably running into big risk with hyperosmolar feeds.
Excellent. And continuing actually for that, what are the problems of EHFs and AAFs, the osmolarity in critically ill children, in sepsis children?
So, Chris, as you know, that was an area that I worked in for many years.
Yeah,
so of course, if there's an indication, for example, if you've got cow's milk allergy, then if you're critically ill, that's what you would continue on. However, you have got gastroparesis, often medically induced gastroparesis. So we have delayed gastric emptying. But my experience is generally, if you go for an EHF, most of them are 320 to 350, your milliosmoles. Those are okay tolerated. The problem that I have found is if you modulate the feeds, meaning you increase the concentration, so you add extra scoops, because often there is this question of, oh my goodness, they are catabolic, you need to get more calories in, so you add all of these, whether that's modular additions. So those we certainly have seen problems with. But for the vast majority, if you stay to, and especially in extensively hydrolyzed between 320, 350, we've got no problem with that. And then think about your route of feeding. We've often found that by bypassing, so if you have gastroparesis, which is really related to your stomach, we often went down to post-pyloric feeding, so place the tube post-pyloric, and even for those, we found that an extensively hydrolyzed feed is good. But exactly want to reiterate what Mikkel said, just do avoid boluses like the pest there.
Fantastic, thank you. Staying with you actually, Roseanne, there's a question moving on now to vitamin and mineral status. You mentioned the monitoring of vitamin and mineral status in the survey. Are there any conditions where you think it's most important outside allergy to monitor vitamin and mineral status?
Gosh, Chris, it's a very complicated question, because the blanket answer is, if you've got a tube down and you're going to nasogastrically fed or enterally fed, gastrostomy fed, most of the guidelines, the ESPGHAN guidelines, also talk about monitoring. So in theory, targeted monitoring should occur. I would say, though, if you have got to really decide, then I would say those children who are long-term, where you predict long-term enteral nutrition, I would monitor. Those children where you've got a polypharmacy, PPIs, because PPIs also change the way the bioavailability of some of the medication, so I would monitor those. And those where you have got symptoms of what Nikhil mentioned before, where possibly excessive losses, whether that's at the top or at the bottom, those would for me be at the higher category. And children who are malnourished, because we know that for catch-up, we don't only need the protein and the energy, you need your other vitamins and minerals. So you can pour in the calories, but if you've not got, if your sodium is low, then, the calories, it won't be used. And the same for vitamin D, zinc, and those kind of nutrients. That would be kind of my priority list. I don't know, Nikhil, what do you think?
Yeah, no, I totally agree with you there.
Perfect, it was great. Okay, Nikhil, you discussed enteral feeding in neurological impairment, and obviously you were involved in that ESPGHAN paper. Are there any risks to enteral feeding in this group, in the neurologically impaired group?
Well, I mean, it's a very complex group of children, and often it's not just about their neurological impairment. I mean, the way I often look at these children is that they have a neurological issue within the bowel. And if we actually think about the gut-brain axis, then often they will have issues around sensitization within the bowel. And that's why often they may not tolerate feeds as well. We know that gastric emptying might be poor. They might retch significantly, depending on what route of feeding. So I think they do carry a high risk of complications such as aspiration, if that's what's predominantly affected in them. I think the other risk is really of misjudging the nutrition that they need, and that's both for undernutrition and overnutrition in these children. And one of the points that we emphasized in the paper we wrote was really around nutritional assessment, of actually having valid ways of being able to nutritionally assess them, to make sure that you're not actually running into nutritional issues and also metabolic issues. I mean, Roseanne, I think, has done a fair bit of work around this, so she might be better placed.
Yeah, I mean, Nico, I totally agree with you. But you know, my involvement has been around energy expenditure measurements, and when we compared, so we did resting energy expenditure, which is largely predicted by your lean muscle mass, and we found also that because lean muscle mass often is very low, their energy expenditure is extremely low. So you often find them that when you start off, they are in a situation where they look malnourished, or they are malnourished, and the tendency is often to pile in and get catch up quite quickly. But the reality is your catch up weight gain is often not the muscle, but you actually get a lot of excessive weight gain. So I think that is something to take into account. So when you make your plan to say the baseline resting energy expenditure is going to be lower.
Yeah, fantastic. That's great. Okay, we've got time for one very last question. So this question has just come in. Are there any benefits to the gut of a variety of food sources in enteral feeding? For example, should we be using different whole proteins rather than always using the same? So, Nikhil, do you want to start with a brief answer to that, and then I'll move to Roseanne?
Brief answer, Nikhil.
Brief answer.
You know, actually, it's there was one point which I didn't make so much, because what I don't want everyone to have the impression is that the gut is a fixed, you know, it function in a fixed way. I think it's one of the most adaptable organs. You know, ever since I've come to Australia, I've been eating much more kangaroo than I've ever eaten. That's of course a joke, and I don't mean to offend anyone, but I think the main thing is that it's constantly adaptable. So therefore, you know, in all our diets, we actually eat a whole variety of proteins anyway. Now, I don't think there's any real research over manipulating kind of protein source, for example, on a kind of daily basis, and what your body will do to adapt to it, because we normally do all of the processing before it even hits the small intestine. I mean, the body is really, really effective at doing that. So I would be a little bit hesitant in terms of small bowel feeding to be challenging it constantly with different proteins every day. But I don't think I can really answer it, because I don't think we really know the answer to that. Roseanne, I don't know whether you have any other insight into.
So I think the principle of the question is that, you know, if we move away from enteral feeding, if we just say food diversity has been shown to be hugely beneficial for the microbiome. So the more diverse your diet, that does not mean the diversity of the protein, whole protein, peptide. So food diversity. And I think for me, the point here is if for those children who if you've got enteral feeding, fine, but for the vast majority that we recruited, there was some oral feeding going in. And I think for me, that makes more sense to diversify the oral diet. So therefore it has got a gut microbiome benefits. And I think that is a good message, just to say, whatever you have available, diversify that.
That's a great message to end in. So before I give some closing information, I'll just take the opportunity to thank Nikhil and you, Roseanne, for your time with the lectures and also for the Q&A session today as well. So thank you so much for that.
Thank you very much.
Lovely. Thanks, Alon.